Okay, guys, so I'm here once again with Nathan. I believe we all know Nathan. His face is very familiar to my YouTube channel. He's been on my channel several times to share some important information to our registered nurses in Ireland. Okay, if you haven't watched my video with Nathan on the adaptation process for RGNs, please do well to watch that video again. Welcome, Nathan.
Thank you, Lucinda.
And thank you for always honoring my invitation. Anytime I call you, yeah, you're ready. Yeah, I have to buy you a very big turkey. Do you like turkey?
Don't worry, I always look forward to that.
Okay, so going straight into today's video, we are talking about some top interview questions for our registered nurses. I understand that when it comes to registered nurses, it's a very broad topic, okay, because we have the medical, we have surgical, we have the government sector as well, we have the nursing homes, Guys, what we are actually going to talk about today will be more like general stuff, okay? You can just have a look at it, so when you are preparing for any interview at all, despite your department, this would also be very useful to you as well.
Okay, yeah. So, like as you rightly said, when it comes to the registered general nurses, the questions are very broad, but it doesn't deviate from the usual norm where the recruiters will ask you to tell them about yourself. So, more like a self introduction kind of thing. And then they move into more specific areas. So, since I work in the surgical department, I may be more proficient with the kind of questions that come with the surgical
Yeah.
types of interviews. So most of the time, they can ask you, how would you manage a patient with a particular surgical condition? They are looking for a broad array of things: your communication, then your ability to be a team player, how you are able to plan and prioritize, how you perceive patient safety, how you handle complaints, all those kind of things. I'm sure it cuts across. But then when you're doing interview for, specialized departments, your questions might be tailored down to what exactly that they are looking for in you.
Yeah.
That's just like a broad overview.
Looking at, let's say, general questions. I know you've already mentioned a few as you just started. Would you want to go in, like, let's say, surgical aspects and medical aspects, or maybe you can just look at some questions that may just come in and how we can go about answering them?
All right, so I did mention about the broad areas that they look out for. So let's say they want to assess you on communication. They can ask you that, how would you manage a deteriorating patient? Or how would you be able to identify that the patient is septic? What are some of the signs and symptoms? And then once you're able to mention the way you identify or maybe how you escalate, they want to see how you would probably communicate that to a doctor. So in this situation, the most popular tool that's used for communicating that is the ISBAR tool, where I'm sure most of you are very conversant with that tool. You probably want to use the ISBAR tool to communicate how you're going to escalate that patient, where the I stands for identification. So you identify yourself, you find out who is on the end of the line. Is that Dr. So and so, or is that this intern? Then you also identify the patient that you're calling about, this particular patient. Then you give the situation. Patient has been presenting with A, B, C, and so that's the situation. And then you give a background. Patient came in with A, B, C, and then your assessments or whatever you did at that state there, that moment, which made you concerned. And then you can give your recommendations that, I think this patient is septic. Can we start septic management? Or, so that's like one of the major tools for communication that's used. You usually don't have a lot of time, so you're also expected to be very straightforward when you are, doing those kind of things. One other thing would be like, how do you prioritize care of your patient when a colleague of yours calls in sick?
Okay.
Then you know that if somebody calls in sick and they're not able to fill in the person's, then that increases the workload.
Yes.
So you are actually expected to take more patients. If you're used to taking maybe 5 or 6, maybe that particular day you have to take like 8. An ideal way to approach that is that, well, all patients have their unique needs and you have to personalize the care. Some people are more sick than others, so you give more attention to those who need your attention and care, and you distribute the available resources. Probably some carers can help you with, I don't know, it depends on each hospital and protocol. Some carers can help you with doing vital signs, activities of daily living, and all those kind of things. Then you focus on the actual nursing. So those are some of the things that you can see when it comes to like prioritizing of your care when a colleague calls in sick. Yeah. Nowadays, there are issues about MDAs, which is Misuse Drugs Act, like those are controlled drugs. They can ask you, what do you do when somebody from a different ward wants to borrow an MDA or another drug from your ward? How do you handle that?
Yeah.
Of course, these are things that has to deal a lot with documentation because nobody wants an MDA getting lost while you were on duty. So yes, you are expected to answer that. How do you go about that? First of all, the person who is coming for the MDA has to bring their MDA book, whatever they have in their ward, and then you do the transfer of the pages to make sure that, okay, this patient from ward A, they came for, let's say, methadone 50 milligrams from our ward. You document same on your ward and indicates their page number in your MDA book as well. The other nurse signs against it. You also sign against it in your book. You both sign the MDA register bank where it captures your name and then your initials and then your PIN number. So it makes it easier that maybe the pharmacist or whoever that is making audits pick the MDA book from their ward. They can be able to see all your details and the person borrowing's details. And if they pick it from your ward as well, they can see all those things. It's just to ensure clear documentation and, transparency. That's one of the things. Also, they want to see how good you are as a team player. So one of the questions will be, how would you be able to help a colleague who has more sick patients? So it could happen that on a particular day, you are favored and your patients are not so sick and you finished your routine early. It's just a matter of asking, hi, is there anything I can do to help you? It could happen, especially like you went on shift one morning and your colleague's patient is extremely sick. It's time for her to start medications, but she hasn't been able to start. And intuitively, you know that medications are time sensitive. If you have finished with your side and you think that the other tasks you have to do can wait a little while, you can cover for your friend.
Yeah.
And do that on their behalf. It's just, a way of promoting team spirit and, being a good team player. And also doing that means that you've put patient safety first because patients who are on certain time sensitive medications get to have their medications on time.
Okay.
So those are some of the domains that questions usually come from. Another thing can be that how do you handle a fall or an incident where a patient had a fall? Falls management is something very important because it can result in harm to the patient. And the last thing that a hospital wants is to be having lawsuits with regards to falls and all that. Although some of them could not have been foreseen, but there are protocols in place to prevent falls. If they ask you that how do you prevent falls, you found a patient maybe lying on the floor and you realize that this patient has had a fall, what you'd first do is assess the environment. Is the patient close to any form of danger? Is there water on the floor? Is there any electrical devices or things like that on the floor? You move the patient away from the danger. You alone as one single individual cannot lift the patient, so you need at least 5 or 6 people to lift the patient up. So if moving the patient away from the floor will not be possible, then maybe you can leave the patient on the floor, do all the other assessments that you have to do, like check your vital signs, blood sugar levels, assess for any injuries. If there are any injuries, you might want to do maybe an X-ray or CT to confirm all that, write an incident report, do a falls assessment, falls reassessment actually, and you have to inform the next of kin about all that. Those are some of the essential things that you do, and ensure that the side rails are up, they have falls prevention, socks, electrical wires, and their bedside is clutter-free. Those kind of things. It's just the simple stuff, basically.
Okay. You just mentioned about side rails, which I just want to ask. I know that when in Ghana, most of our beds have side rails that you can just pull up and then that's it. But here they always mention restrictive practice. Would you advise someone back home to actually mention that in their interview?
I will advise that you can.
Or unless it's part of the care plan.
Yes, because if a patient is falls risk and they are somehow disoriented, you can raise the side rails. You are not physically restricting a part of their body. You are just putting up the side rails so that if they are sleeping and they roll to the side of the bed, the side rails are there to catch them so they don't fall.
Okay.
Yeah.
Okay, that's good. Okay, guys, so now let's have a quick look at some few interview questions as well, and then we'll come back, and if Nathan has some more questions to also share with us, he can go ahead as well.
think sometimes nowadays they are asking questions about end of life care.
Okay.
And resuscitation and those kind of things.
Yeah.
So we didn't actually talk about the, how you go about it, just the question.
Or you can mention a few things. It's important. I like it. Yeah.
All right, sure. Yeah, so just to mention a few more things that you can expect would be like, they can ask you have a patient who is approaching end of life. How do you care for that patient who is at end of life?
Yeah.
So one key thing you need to keep in mind here is that it's a very sensitive time for both the patient and their family. Your communication has to be on point. Making the patient as comfortable as they can, is one of the essential things that you do. Making the family members, feel welcome and comfortable, maybe giving them a cup of tea along the way, providing information leaflets, especially like what happens right after the patient passes away, like the protocols and all that things, explaining to them in a very calm and reassuring manner, and letting them know that we're always there to help them should they need anything. That's one of the ways you can, you can prove that you're actually there for them.
Yeah.
So one other thing could be that how do you escalate or how do you handle an emergency situation?
Yeah.
So you're there and then you just realize your patient becomes unresponsive, or you're there and you realize that the patient went for surgery and has massive bleeding. How do you go about those kind of things? In most hospitals, we have like a rapid response activation code. You can just call that number. If it's massive hemorrhage, you state the ward's name, the bed number, and then what is actually happening. And then the emergency response team comes around. It cuts across. I'm sure every hospital has such protocols. It's up to you to familiarize yourself with the protocols that are available at your workplace. And should there be those emergencies within the ward, what can you also do while you're waiting for the emergency activation team?
Yeah.
So you have your crash trolley there. At least you can clear the bedside, remove the end of the head side so that if they want to do resource, everything ready, just that when the team comes, they can do their work. Once you've realized maybe there is a need for you to commence CPR, maybe a patient has become unresponsive, there is no pulse and all that, you start doing the basic life support activities while you're waiting for the advanced life support team to come around and take over the care. That will be one of the things. Medication administration. So when questions come around, how do you ensure that medications are safely administered? Your key should be the medication administration rights. Mention all the rights, right patient, right time, right route, right information, all of them. You already know them. So these are just like tidbits. It cuts across. Just be ready for any of those things.
And then also in an instance where there is a medication error, what you would do?
Great. So when medication errors do happen, there are a number of things, at least from my place. You have to do open disclosure. You have to let the patients know that you actually gave a wrong medication or there has been an error. You complete an incident report stating the facts, what happened and all that. You have to let your manager know, of course, about the whole thing. Then you have to retake your medication competency assessment again, because it means that something went wrong somewhere. So you have to be reassessed before you can give those medications. So those are some of the basic stuff.
Okay. So now chip in a little bit of anything surgical.
Well, so in most surgical departments, let's start from the head all the way to the leg. So you have a patient who went a maxillofacial surgery. There are certain specific observations they do for the patient. I don't really have much information about that. But let's talk about patients who have undergone like ENT surgeries, like they have a tracheostomy or a laryngectomy and those kind of procedures done. You want to ensure that their cannulas are patent, it's not plugged with mucus, which will impede their respiration and other things, because you have a patient who is not breathing because their tracheostomy is blocked, or then you're literally killing the patient. Every ward will have the protocol on how frequently you check on that patient, how frequently you suction, how to do your assessment with like checking the size of the inner cannula, which goes into the tracheostomy and all that, and changing it, and how to humidify the tracheostomy. So questions like that would
Like
kind
that.
of, they can also ask you that, so you went to see a patient who has started turning blue and is less responsive. What would your mind go on first? Of course, cyanosis tells you that patient is losing oxygen supply.
Yeah.
Why is the patient losing oxygen supply? Probably because the tracheostomy is not patent.
Yeah.
So that should be your first line of thought, and then you initiate your interventions, remove the cannula suction, clear the airway, and So abdominal surgeries, they can ask you, how do you prepare patients before surgery? The goal of surgery is to minimize sepsis as much as possible. So skin preparation is one of the main things. Patient education ahead of the surgery. Patient to know that after surgery, they have to start mobilizing as early as possible. Lines and devices, and probably how those lines and devices can be managed. You have to educate the patient on most of those things, and sort of getting them optimized for the surgery.
Yeah.
One thing is the diagnostic investigations that needs to be carried out prior to the surgery, like group and hold, group and cross match, full blood counts, maybe their coagulation factors, because some patients are on blood thinners. Those are things you would want to do. Maybe some of them would require an ECG and maybe x-rays and other diagnostic stuff prior to the surgery. It's your duty as a nurse to make sure that those things are done before the patient is wheeled to theater. Yeah. And also ensure that it is the right patient that is being sent to theater. You don't want a situation where two patients with the same name and you end up wheeling the other one to theater. That would be very disastrous. Yeah, so that's one of the things. And then you're receiving a patient, so your post-op management from theater. What are you looking out for? For me, I would say generally the patient's general outlook, level of consciousness, have they fully woken up from the effects of anesthesia? And you look at the wound sites. Is there any signs of bleeding? Are there in any distress? Look at the vital signs. Are they within stable parameters? If they are, and you're happy to take them to the ward, fair enough. If they're not, you have to address your concerns with the recovery nurse or maybe the anesthetist who is present there. And then post-op observations. These are all things we know, like 15 minutes, then 30 minutes, and 1 hourly. And then, once the patient begins to stabilize, you do your routine observations of their vital signs and come across questions like, how do you manage a patient on PCA? PCA is like patient-controlled analgesia. Mostly that runs through infusion pumps. We have other forms of pain management like epidural pump, paravertebral pump, and then infusions. So all those pain management medications goes through pumps, and so you need to know how to do the checks and 4-hourly checks and those kind of things. Sometimes if a patient is diabetic and going for surgery, they are placed on insulin infusion along with some IV fluids. We call it atrapid, variable infusion protocol. That's something you should also be aware of, how to manage a patient like that. Post-operatively as well, there are other things that the patient may come back with, lines and devices, central lines. So you need to know how to use a central line or a PICC line, or drains and all that, caring for those drains, ensuring that there is no infection. So those are some of the things that you should be ready for if you're applying for a surgical position. If you're applying for a medical position, you should know more about maybe things like EVO, BiPAP, CPAP, helping patients with COPDs and stuff like that. Because you will definitely come across those conditions more in the medical wards. In more specialized areas, like patients are on heparin infusions. Heparin administration has to, go with regular coagulation checks. It depends on the ward and the protocol. So you need to know about all that. And maybe your patient's potassium levels goes high and patient needs to be on hyperkalemic protocol. So you need to know how those conditions are managed, and you should be able to explain yourself to convince your new employer that you know the job and you can do it. So that's it.
Okay, Nathan, thank you so much. This has been very helpful. At least he wasn't able to mention like everything, which I'll definitely display most of the questions on the screen. But at least he's been able to pinpoint some important topics, and then he's been able to kind of mention some important things that you should also include during the interview as well. It doesn't mean that if you have anything more, why not? You can still add up. He's been able to at least highlight some important points as well. So also add yours, and also remember to be very confident in your interview. Was very very important. Sometimes when I even lie and cry, and the confidence level is there, at least they give you that plus. Yeah,
Exactly. Exactly.
give you that plus. So that's so good. Thank you so much, Nathan. Thank you guys.
You're
If you
welcome.
are here and you have any other question that you still want to let us know, just drop it under the comment section. And please remember to encourage us by liking the video and also share with your colleagues as well. Thank you guys so much. Thank you, Nathan. See you all soon on my next video. Bye.